And what I do in my research is I look at, along with my research group, I look at whether or not the patients with stroke are recognized when they're calling into the emergency medical services, whether that be the 911 equivalent in Denmark, which is called 112, or the medical helpline, which is sort of the out-of-hours service, although in the data I look at, it's a medical helpline that's up 24/7, so people can always call. And what we look at is whether the call handlers or dispatchers, whatever you want to call them, do they recognize that this is a stroke case? And do they get the patient the help they need? Do they send an ambulance, get them fast to the hospital? And working with that data, we're trying to show that you can use artificial intelligence or machine learning more specifically to actually enhance this and make a supportive tool for these call handlers to help them recognize stroke in these audio calls. So what we showed was that for the 911 equivalent line, there was a lot of stroke cases not being recognized, about a third. And for the medical helpline, it depends on how you look at the data. If you look at it broadly and say that, well, they have to say that this is a stroke, it was only 1 in 4 that was recognized. If you look at it more narrowly and say, okay, well, as long as they have given they have to have given a specific diagnosis and then it can't be stroke, then it's about half that they recognize. So that's a lot that they miss. And worse on the medical helpline, which is not the one we advise patients to use, but in our data we can see that on all calls to the EMS, it's not half, but it's getting up there. It's about 11,000 that call the 911 line. It's about 9,000 that call the medical helpline of strokes, and that so a lot of people are not getting to the hospital at the time. We can see that reflected in our other registry data, where over half the stroke patients are not getting to the hospital in time for example, thrombolysis. It helps to visualize or think about, well, what's the challenge for the call handler, because the call handler are not generally stroke experts. The call handlers are, in our case, paramedics and nurses, and sometimes physicians, but not necessarily neurologists or, in other way, cardiovascular experts. And so they have to triage everything. They have to triage the broken legs, the pregnancies, the poisonings, and the strokes. So they have a great deal to sort between, and so it's difficult for them to handle strokes. For example, in the data set we used for the machine learning, only 4 in 1,000 calls were a stroke. So that tells you how difficult it is for them. And so we're thinking that with an automated detection of stroke using this machine learning technology, we might be able to enhance their recognition and to give them that boost to say, oh, this could be a stroke. Should I act on this and send the ambulance and then get more stroke patients to the hospital fast? So what we did was we took this data set. We're fortunate in Denmark to have very robust registries. So we took all the calls to the EMS service, and we linked that with the dispatcher suspicion of stroke, whether or not they suspected it, just a yes or no. And then we linked that with our stroke registry, where all strokes treated in hospital stroke units are registered. So now we had a data set where we could say, okay, this is a call that was made. It was made by a patient with a stroke, yes or no, and it was recognized by the dispatcher, yes or no. Using that data set, we could get a machine learning algorithm to first transcribe the call, and then to analyze the call to see whether there were patterns related to whether it was a stroke call or not. And then to, using that, make a prediction on, if it was given a new call, whether this is a stroke, yes or no. That's the basis of it, really. What's important is we did this on data from 2015 to 2020. So it's about 1.5 million calls in the data set. And then we tested it on data from 2021. Which was about 344,000 calls, and respectively for the training data set we had about 7,500 strokes and then 750 strokes in the training data set. And what's good about that is that since we use a data set that's completely different from the training data set for testing, we're certain that it doesn't just learn which of these specific cases are strokes, but it learns patterns. And we can also see that when we sort of try to open the black box of the algorithm. So usually you can't really say what is the prediction on this specific patient from. It's an advanced neural network, so there's a lot of processes when you crack open the code. But we can see on the large scale which words are highly predictive of it being stroke or non-stroke. And we were really encouraged by this because we can see that the words used for a stroke case that are highly predictive are things like which side of the body they're talking about, having a double vision, slurred speech, feeling weak, needing an ambulance, words we would normally associate with stroke, whereas the words that are highly associated with not being a stroke call, those are things like having pneumonia, pregnancy, needing over-the-counter medication, things we wouldn't really associate with an acute stroke call. So that was really encouraging for us. And we can see in the data set we have the results, and we, as said, in these results where we're very conservative in saying when we were a bit large when we're saying, well, how many are recognized by the human medical call handler, they recognize about 53% of strokes in the case where we're fairly inclusive. But for the machine learning algorithm, it recognizes 63, so that's a 10 percentage point higher recognition. And notably, we achieve a positive predictive value, which is how many, when it's suspected stroke, how often is it right? Of that, we achieve for the human call handlers 17.1%, but for the machine learning, we achieve almost 25%. So that it does better on both parameters, and that's important because usually if you get a very high recognition or sensitivity, but then the positive predictive value tanks, well then you just have an algorithm that overloads the medical system later. So that was important for us. What we did, we tried to make it as simple as possible because this is the first time that anyone has done any of this. So we wanted to make sure you could do different things. You could do things with audio. So you could potentially look at speech patterns. This requires a very robust base recognition of speech patterns because if you have a very heterogeneous group where there's a lot of differences in how people speak, it would be more difficult to get the slurring of speech, the stilted pattern of speaking for a patient with aphasia, for example. But you could look into that, or you could look into, well, get some more data behind. So if you have a system where you have the patient's age, the patient's medical history, the patient's gender perhaps, or sex, I should say, then you could maybe get this to the algorithm, and that might improve the algorithm as well. So there are possibilities for enhancing this, but all of it requires robust data and a robust infrastructure digitally.